Hi, everybody. Thank you for joining us today and utilizing the resources that Deep Sea Foundation provides over at their educational YouTube channel at Deep Sea Foundation. But you can also listen to our podcast at Deep Sea Journey, and that you can listen to on Apple Podcast, on Spotify, and Amazon Music. I'm pleased to welcome and introduce Dr. James Craigie, who is a board certified surgeon specializing in and trained in microsurgery. The primary focus of his practice in Mount Pleasant, South Carolina, which is outside of Charleston at the Center for Natural Breast Reconstruction, is performing complex breast reconstruction procedures, which we're going to discuss in the interview today. I do want to highlight that Dr. Craigie and his team practice the co-surgeon model, meaning there are two microsurgeons as part of the team that performs autologous breast reconstruction at their practice. So there's lots of acronyms, terms, and procedures that patients hear about either in consultation with their plastic surgeon, or they can hear them online and social media. So really, at the foundation, our focus is to provide accurate information to our listeners. And it's why I ask you to join us today, Dr. Craigie, to talk about a couple of specific procedures. So delighted to have you back.
Thank you so much, Terry. It's always a pleasure to talk to you and see you and uh, get a chance to speak to your listeners.
Yeah, yeah. So today we're going to take a closer look at something I'm not sure everybody knows about, but they need to. It's called delayed deep. So why don't we start out? Give us a little bit of an explanation of that, and then what type of reconstruction it's actually used for. Dr. Craigie, I'll let you take over.
Great. Thank you again, Terry. Yeah, so there's a lot of confusion that often comes up in breast reconstruction because we use the term delay and we use the adjective delayed and in reference to different breast reconstruction procedures. But delayed breast reconstruction is a term that is applied to reconstruction that is done after the mastectomy, and that's more of a description of breast reconstruction. But what we're talking about is the delay procedure, which is actually a procedure unto itself, just like the DIEP flap is a breast reconstruction procedure. The delay procedure is a surgery unto its own, which prepares the body, and in this case, the DIEP for reconstruction. So it's done actually before the actual procedure. And the delay procedure is certainly not something that's new. In fact, it's one of the original concepts in the foundation of plastic surgery. It goes all the way back to 1517 or the late 1500s when Tagliacozzi performed nasal reconstruction. A lot of that had to do with a delay. And that was the beginning of plastic surgery. And then again, what a lot of us call the beginning of the modern era, Sir Harold Gillies, post World War One, performed the delay procedure extensively for breast reconstruction. So it's not really that new, but it's newly applied to the DIEP reconstruction.
I love that history. Yeah, we've done some on Howard Gillies before, and that was during the war, World War One.
One.
Yeah, yeah, yeah. Yeah, he's an interesting guy. Glad you brought that up.
Yes.
Um, Tell us a little about the procedure itself, you know, how it
Yeah.
works. I
Sure.
love, by the way, I love that definition that you said it's preparing the body for deep. I was writing down notes as you were talking.
Yes. Yeah. It is. It's a procedure where it's a luxury to be able to, in advance of doing a reconstruction where you're creating a flap,
Mhm.
basically you're borrowing from one part of the body to create or reconstruct something that's been removed. So when you can plan and make steps that improve that procedure or make it more predictable, and that's what the delay is about. Essentially, before the DIP, the way I do this, we go to surgery and we actually make the incision. We leave the corners attached, and then we basically lift the flap up. In advance of that, we have an MRI, the MRI angiogram that shows me where the blood supply, the different blood vessels to the tissue that we need are. And so essentially by finding the one that I want to use, and I feel like it's the best, and there's a lot of different criteria that go into that, I then get rid of all the other blood supply that is overlapping with that blood vessel. And so the body immediately reroutes all the blood flow through one blood vessel that we're going to be using for the flap procedure. So essentially then what happens is within 24 hours, and we can talk about timing as well, the body extends the territory that one blood vessel can reliably and predictably nourish. And so it takes a lot of the variability out of the blood supply and increases the chance of having a better result, and essentially getting more tissue at less of a cost to the donor area. So it is many advantages. Again, I do it as short as 24 hours before the actual DIP, and the effect is permanent. However, there's a window where we want to make the most of it. We don't want to wait longer than 2 weeks. So essentially, what I try to do is 24 hours to approximately 7 days after doing the delay procedure, then I actually do the DIP.
Okay, so you're optimizing, you're really rerouting, cleaning up. I'm using layman's terms here based on what you just told me, cleaning up some blood vessels that aren't going to feed into the flap. Anatomically, I'm trying to get a picture because I didn't have this particular delayed procedure done, Dr. Craigie. Anatomically, so it's in the breast area, correct?
No, the incisions would be in the donor site. So for DIP, it would be on the abdomen.
Yeah. Okay, that makes sense. That's why I wanted to ask you, because I'm picturing this in my mind as the patients on the table. So you're rerouting them in the abdominal area. How big of an incision is the delayed procedure before you do it? And I mean, how careful does the patient have to be in that window of time, either day before or week before? And I'm asking obviously because if I were a patient, I would want to know. And I think there's going to be patients that ask when they or wonder when they watch this video.
Yeah, absolutely. So the incision is essentially the same incision that I will use during the DIP,
Okay.
except for a couple of things. One part of that is on the very corner. So you've seen basically, the markings of a DIP tend to be like a triangle of sorts. So the corner is off to the side, and the middle is kind of the base of the triangle, whether it's one or two reconstructions. So that corner, basically the last 5 centimeters of that corner of a triangle is left attached to the body, and that's important. Otherwise, the complete incision is made as if I were taking the tissue and about to remove it and then put it on the breast and do the microsurgery. Except I'm going ahead and dividing all the blood vessels that normally we wouldn't be using and preserving the one that we will use. And so then when it comes time to do the DIP, the corner is completed and the procedure proceeds exactly like a DIP. So the vessel that's been prepared is ready. And then that is basically the part where we dissect and prepare that blood vessel if it's a DIP, then as it travels maybe through the fibers of the muscle, or maybe if it's a blood vessel that runs around the muscle, that part until the blood vessels get big enough to attach to the internal mammary vessels or the blood vessels we're connecting to. So that proceeds in a normal way. But the reason the incision, as you mentioned, is basically like it would be, but nothing's taken away. So when the patient wakes up, we've done a lot to proceed, and so there's a lot of, we create laxity in preparation for the closure to come. We also repair the muscles in between, in the middle of the abdomen, and so that creates some loose tissue. And essentially then we close things back up and put a drain. And so patients can wake up, they can go home the same day. Normally my patients tend to spend the night, depending on their situation. Clearly, if we're going to do the DIP the next day, they spend the night. If not, sometimes I'll do the DIP or the delay procedure on a Friday, and they'll come back the following Tuesday. So they can leave the hospital, they can be up and around, they can walk, they can do things. We don't have our patients doing heavy lifting. There's a drain in place. Typically, we say avoid driving if you've required any pain medicine. So you're not in bed. You're not confined to the hospital. You can be out doing things, just not impact exercises and heavy lifting. And
you know
and so
what?
it's a lot.
You
It's a
close the
lot.
loop. You close the loop for me. You know why?
Mhm.
Because deep flap is a oh, I've lost the word now. It is, you're taking the whole flap off. I can't think the word I was trying to come to my mind, but you're taking, it's a transplantation. That's the word I was looking for. Deep flap is a transplantation of a flap up to the breast area. You don't quite, you're leaving it intact for the delay procedure until you do the deep and the transplantation. You totally close the loop. That was a great explanation for me. I'm a visual person, so I'm sitting here visualizing it as you're talking about it. That was really a great explanation. Can I want to segue into a couple other topics if we can. There's other acronyms that we hear about, and I've talked about it before on the educational channel, but I kind of want to revisit it and talk to you a little bit more about it in depth. Is the SIEA, and what, tell the listeners what it stands for. What's different about that than the perforators you look for the, I know you're looking for it in a deep flap, but it's a different layer, I guess, of perforators.
Yeah, yeah, no, that's a great question. That ties into the delay procedure. The tissue of the lower tummy that we want to use for the DIP breast reconstruction, the blood supply to that area, just like all over the body, comes from more than one source. So there's an overlapping blood supply. So you'll have large arteries and veins. They look tiny, but they're large because we can see them with our eyes and under a microscope. And then those blood vessels go into the tissue, and then they send out their spider web of tiny blood vessels that eventually interlac and overlap with each other, and then nourish the tissue. And so it's kind of like your fingerprints. Everyone has them, but they're all very different. So the SIEA is a blood vessel that kind of works with the deep inferior epigastric blood supply to the lower tummy that we use for breast reconstruction. And so the SIA stands for superficial inferior epigastric artery, compared to DIP, which is the deep inferior epigastric artery. And so if you think about, okay, a deep, that means, well, this deep. Superficial, well, that's superficial. One of the highlights of that, because the deep is deep, the perforators go under the rectus muscle and come through. They're coming from below, underneath. The superficial doesn't travel through, its branches don't travel through the muscle of the tummy. They travel superficial to it. And so the advantage of that, if you can prepare the tissue and find the artery and vein that will nourish the tissue you need, then the huge advantage of not having to open the lining that goes around the rectus muscle, not having to really work through the muscle at all. And And so that's an advantage because there's less discomfort to the patient. Anytime you open and spread the muscle, you run the risk of damaging or scarring the muscle or potentially injuring a nerve. And so we're always very careful for that. But if we like to take a very low chance of a problem occurring and making it zero or no chance, that is the wonder and the attraction of the SIEA. Problem is,
I bet you're going to answer what I was just going to say. Go ahead, Dr. Craigie.
it's kind of the holy grail of breast reconstruction. And so why don't we use it all the time? Well, there are challenges. All the blood vessels are different. The human anatomy has so many variables. The bottom line is not the SIEA is not present in all people in a situation where it can be used. It is also in a position that's vulnerable to incisions like C-section or appendectomy or other surgeries on the lower tummy. And sometimes it's divided because it is a superficial, it's not deep. The deep is hidden and kind of protected below those muscles. But even, sometimes C-sections can involve that, but usually it's protected. So the superficial is not always present. The blood vessel, when you prepare it, there's a lot of variations, and sometimes it just doesn't match with the internal memory vessels that we normally connect into. So the surgeon, the flap itself has a higher failure rate than the DIEP. So that tells you something in itself. So there's advantages and disadvantages. We tend to, we want the operation to be successful. We can't appreciate the advantages of that approach if it doesn't work. So for that reason, it's not as frequently used. It's kind of used when present, and actually the delay procedure has made it possible that we can utilize that option more often. And it has to do with basically the delay procedure, being able to make your incision, prepare the blood supply, make sure that if you use that artery, that it's going to nourish the tissue that you're going to need to transfer. And so since I've been doing the delay, I've increased the number of times I've been able to use the SIEA. However, it's not going to always be available no matter what, but it's something that shouldn't be ignored because when it can be used, it's a great advantage.
You answered my question. What I was going to say is, in a perfect world, SIEA would always work because
That would be nice.
in a perfect world, we all have a different footprint for our blood vessels, just like we do for our facial expression and all the things. So yeah, that was great explanation. There's another procedure that I don't hear of very often, but I would like to talk about it. It's a TDAP.
Yes, great.
Tell
Yeah,
us.
that ties in well. So the delay procedure is kind of opened the door. It's made certain procedures maybe more reliable and more predictable. And so the TDAP, thoracodorsal artery perforator flap, is essentially the blood supply that comes from under the arm, and it tends to nourish. It's when someone has an axillary dissection or sentinel node, that artery is in that vicinity. It's the artery that normally sends a blood supply to the latissimus dorsi muscle, the largest muscle in the body. But it also has what we call perforators. Just like the DIEP, the P is a perforator, allows us to use the fat but save the muscles. The TDAP allows the latissimus dorsi muscle to be preserved, yet still use the fatty tissue that's in that area, kind of the bra strap mark, and going back to the back, allows that tissue to be utilized for breast reconstruction. So as you might imagine, that's in the area of the breast. And so it's close by and oftentimes can be rotated and used for breast reconstruction, depending on how much fatty tissue someone has there. um, depending on a lot of factors. And so it's an option of using the same area that you would use if someone had a latissimus flap. You have latissimus flap, it's getting tissue from that same area, but you're compromising and basically utilizing the largest muscle in the body to drag that blood supply with the fatty tissue. And so everyone's different. That part of the body is a little bit different, and you have to, in order to get enough fat, usually for reconstruction, you kind of have to get more of the tissue that is directly over the muscle, more of the tissue that is directly over that perforator that you're going to choose. And so the TDAP flap has always been done. It's been done, it's not a new procedure, but we've added doing the delay to it. And so by doing the delay, then we can more reliably extend the amount of tissue that one would get from that area and utilize it for reconstruction. So it's more useful because now we can get more tissue and avoid having to destroy and remove the latissimus dorsi muscle. And so it's very useful if someone's had a DIP that hasn't worked and the internal mammary vessels aren't available to do a microsurgery procedure. The donor, if that's the best donor area they have, then it can be a very useful option for reconstruction. It can, and with adding the delay approach to it, now we're able to, in some cases, reconstruct the entire breast, whereas before maybe the TDAP could reliably get enough tissue to do partial breast reconstruction or, a smaller reconstruction. So anytime, we always want more for less. That's always good, right?
Mm-hmm.
And so it's particularly helpful when we're dealing with someone's natural tissue and what we call the donor area, because we want what we need to rebuild what we need to, but we don't want to damage the area more than we need to. And so that involves avoiding taking the muscle, things like that.
Wow. And this has been a great conversation. If I was a patient who had had a failed DIEP flap or was not a candidate for DIEP flap, like what question would I come to your office saying, well, I heard about TDAP or I heard about, what questions should they ask you about the TDAP and if they're a candidate? You've
Sure.
kind of covered it, but I'm wondering what actually a patient would ask you.
Yeah, I think it starts with what we like to do is with each individual say, okay, we need your own natural tissue. And so where do you have it? Where can we get it and not cause a problem? Where can we obtain it and maybe do something that's positive? So that's why the lower tummy is the most popular way, because we try to perform a tummy tuck effect in the process, make the most of the positive. So if someone feels that they don't have tummy tissue, someone's already had a tummy tuck, someone has a flat tummy and doesn't want a scar, and they feel like they have more tissue in the back, then that would be an option. It has, well, I don't know that it's really an advantage, but like I said, it can be done without having to do microsurgery.
Mm-hmm.
So in other words, you can do it as microsurgery, but you can also do it by just rotating it and leaving it connected to its source. So if someone's had another surgery that's affected the normal blood vessels, the internal mammaries, they may not be available to use again. So one of the positives is this is a flap that we don't have to go under the microscope to do. We don't have to run the risk of that microanastomosis.
So is it considered a type of pedicle flap then, like the flat flap?
It typically is, but like I said, it can be done as a free flap, and you can do that if it's maybe the first time you're doing a reconstructive flap on someone. In other words, they haven't already had a failure.
Mm-hmm.
And so, but typically it can be done as a pedicled flap and then rotated into position, leaving it connected to its original blood supply.
Mm-hmm. Dr. Craigie, this has been really a robust conversation because what you've done is a great explanation of these acronyms that sometimes just kind of get, mumbled in our heads when we hear them. But also, I think more importantly, you've given hope and options for patients who, may need a little bit more specialized microsurgical procedure when they come to see you and what you can do for them. So I really appreciate all your conversation today and everything that you shared with us. Anything else you want to add before we close up?
Yeah,
Close
I
up.
would thank you
That was a
for
tongue.
the opportunity.
Yeah, before we close up.
Absolutely. I think I'd like to shed some light on an issue that is kind of appropriate for the discussion of the delay. Uh, um, and that is when we talk to our patients, we want to think it's important for them to have an idea of how many surgeries are they going to have. We talk about reconstruct, we talk about the DIEP, but essentially we all know that, except in exceptions, it's a staged procedure, the reconstruction, and requires more than one and often more than two surgeries. And then how long is someone going to be in the process of reconstruction? And some people are curious, well, what are the advantages of the delay? And since I've been doing it for the past 3 years, and I've done over 2,000 of these flaps before I did the delay, is that essentially I'm getting my patients through the process sooner with fewer surgeries. Um, Up front, when we do the delay, yeah, I call that one phase, but it's actually two surgeries. So two surgeries back to back, followed by a final surgery in 3 months is our goal with just about every patient. And so what we're trying to do, what we've always tried to do, we want to get closer to being done with each surgery for each patient, so that it shortens the amount of time that they're in this reconstructive process, and decrease the number of surgeries they have. And the irony of it is, by doing a delay, which is an additional surgery up front, my patients are having fewer surgeries, and they're getting done sooner, and with a less involved revision in 3 months. And so, really, that's kind of the take-home message for me, and the reason that I continue to do it every time I can. There are times when I can't do it, and it doesn't mean that it has to be done, but there are always advantages. And I think it's important that patients be aware of, have some idea of how many surgeries am I going to have? How long is this going to take before I'm done?
Yeah, I always say breast reconstruction is not a procedure, it's a process.
Hmm.
That's why I phrase it a lot of times. So yeah, really important. And you're working with a master. You're working with two masters, but I always think of
Yeah,
Dr. Allen, who's practicing with you. He's like the father of deep flap in a lot of respects. So yeah.
he's the world expert and pioneer, and I'm very fortunate to have excellent partners. And like you said, we're in this school that we believe there should be two of us.
Mhm.
And it's Dr. Klein and I have been doing this together since 2002, but also we've been working with Dr. Allen since 2002 as well. Now, fortunately, he's spending more time in Charleston, and so we get to do more. And we like to collaborate, and our goal is to make things better for our patients, and we never stop.
You know what, Dr. Craigie, I am so glad you brought up the team approach, the co-surgeon model, because you have been doing it for a long time. You know what I saw recently is there's a recently published paper, which there aren't a lot of, on the value of the co-surgeon model. I don't want to dive into that today. That's a whole nother topic.
Do
But
another one on that.
yes, yes. But I did a recent study just came out on that, which I'm really glad to see because
Mhm.
it is such a valuable approach. And you guys been doing it for the duration of your practice, really. So yeah. Hey, great to see you today. Thank you so much for spending time with me and carefully, I'm using some weird terms today. I was going to say carefully dissecting this topic.
That's good. That's okay.
Yeah, yeah, it's very appropriate to this conversation, but it's always great to see you. And yeah, let's do another one sometime soon. You're full of valuable information.
It's an honor and privilege. Thank you so much.
All right. Thanks so much for joining me today.